Welcome back to the deep dive. Today, we are diving deep into a specific set of revision notes, your MSRA notes on pediatric umbilical disorders.
That's right. And the plan today is really to take these notes, which, can look a bit dense on paper, and kind of unpack them, make them into a clear, high-yield guide for your revision.
Exactly. We want to make sure the really key information actually sticks.
Yeah, think of it like we're walking through them with you, pulling out the crucial bits, the things that might trip you up, and just helping you connect the dots.
So it's not just memorizing facts, it's about actually understanding why.
Precisely. Transforming that info into real understanding.
Okay, let's jump right in then. So, pediatric umbilical disorders, these notes are focusing on, well, a few specific conditions affecting the belly button area in infants and kids.
Yeah, knowing these specific ones is foundational, really. The notes call out four you absolutely need on your radar. Umbilical hernia, then omphalitis, that's the umbilical infection, umbilical granuloma, which is like excess tissue growth, and finally umbilical polyp, described as a benign growth.
Okay, those four. Hernia, omphalitis, granuloma, polyp. Got it. The main players.
So, thinking practically, if you're seeing a child, what do these actually look like? The clinical presentation is probably the most high-yield bit for just identifying them quickly.
Yeah, what are the clues?
Okay, so for an umbilical hernia, the classic thing is that visible bulge, swelling right around the umbilicus. And the key features, the things to really remember for revision, are that it's typically painless, and crucially, it's reducible.
Reducible. That's a big one, right? You can gently push it back in.
Exactly. Now, contrast that with omphalitis, the infection. Yeah. Totally different picture.
Okay.
Here you're seeing redness, swelling, warmth around the area. Off there's discharge, sometimes with a nasty smell, frankly. It'll be tender, and because it's an infection, the baby might have fever, look unwell generally.
Ah, so those systemic signs are really important flags there, not just a local thing.
Definitely. Think heat, pain, swelling, discharge, all the classic signs of infection, but right there at the umbilicus.
Okay. And the granuloma?
Umbilical granuloma, you often see this a bit later, maybe after the cord stump has fallen off. It looks like a persistent, moist, kind of pinkish lump right where the stump was, sometimes a little clear or yellowish ooze.
A moist pinkish lump, that's the visual cue there.
Yeah.
And the last one, the polyp.
The umbilical polyp is described more as a soft, fleshy growth, maybe a bit more structured, like a polyp you'd think of elsewhere, compared to the sort of wetter lump of a granuloma.
Right.
So maybe a quick memory tip.
Yeah.
Try picturing them. The soft, coachable bulge is the hernia. The red, angry, maybe smelly infection is omphalitis. The moist pink lump left behind is the granuloma. And the distinct fleshy growth is the polyp. Their appearance really helps tell them apart.
Okay, that makes sense. But if you see one of these, what else could it be? I guess that's where differential diagnoses come in, especially for exams. What do the notes say?
Good point. For the umbilical hernia, the main differential is, well, other types of abdominal wall hernias, though umbilical is way more common right there.
Makes sense. And for omphalitis, the infection?
The notes stress telling it apart from just general skin infections, like cellulitis that might be nearby, but aren't really in the umbilicus itself. It's about the focus of the infection.
Gotcha. Granuloma.
Could be mistaken for other benign skin things, little growths around the area.
And the polyp. Sounds like it could look a bit like the granuloma.
It can, yeah. So you need to distinguish it from a granuloma, definitely, or sometimes other rarer abnormalities. Being able to say, looks like X, but need to rule out Y and Z, that's a key skill, and these lists guide you.
Okay, so let's back up a bit. Why do these things happen? The causes, the etiology, and the risk factors are actually quite different for each one.
Right, understanding the why helps. So, umbilical hernia.
That one's pretty straightforward conceptually. It's just a weakness in the abdominal wall, right where the umbilical cord vessels used to pass through. That spot didn't close up completely after birth. A physical gap, basically. And are some babies more likely to get one?
Yes, the notes list specific risk factors. Prematurity is a big one. Preemies often have weaker abdominal muscles overall. African-American ethnicity is noted. Family history can play a part. And also anything that increases pressure inside the abdomen, like chronic coughing fits or maybe fluid buildup, can push things through that weak spot.
Okay, structural causes, genetic links, pressure factors. Now, contrast that with omphalitis, very different cause.
Totally different. This is a bacterial infection getting into the umbilical stump. The notes even mention the likely culprits, often Staphylococcus or Streptococcus. So it's an external invader.
Which naturally leads to different risk factors, I imagine.
Exactly. Poor umbilical cord care is a major one. If the cord stump stays on for a really long time, prolonged separation, that gives more time for bugs to get in.
Yeah.
If the baby's immune system is weak for some reason, and just generally unhygienic conditions around the baby.
So it's a really useful contrast for revision, isn't it? Hernia risks are often sort of structural or genetic, while omphalitis risks are more about infection control, environment, care practices.
That's a great way to frame it. It helps keep them straight.
Okay, what about the granuloma? Why does that happen?
That's down to incomplete healing after the cord separates. Instead of nice, smooth skin covering the base, you get this little overgrowth of granulation tissue, like the healing process went a tiny bit overboard locally.
Right. And the polyp.
That comes from bits of the umbilical cord itself, remnants, that just didn't disappear as they should have. Interestingly, the notes actually say the exact reason why these remnants sometimes decide to form a polyp isn't fully known, just that they persist.
Huh, okay. Little bit of mystery there.
So we know what they look like, why they happen, maybe quickly touch on the pathophysiology, just the how it develops, cause to effect.
Yeah, connecting the dots.
For the hernia.
Yeah.
Simple. Weakness lets the abdominal contents bulge out.
Omphalitis. Bacteria get in, body reacts with inflammation, redness, swelling, heat.
Granuloma. Healing doesn't complete properly, leaves behind that excess tissue.
Polyp, those leftover cord bits just persist and form that fleshy structure.
Understanding that sequence helps make sense of the signs you actually see.
And just briefly, how common are these? The epidemiology section in the notes gives some UK context, right?
Yeah, it highlights that umbilical hernia is actually really common in infants, especially, again, in premature babies. That's a key takeaway fact.
And the others, omphalitis, granuloma, polyp.
They vary much more. Things like omphalitis rates really depend on, hygiene standards, access to good postnatal care. Makes sense given the cause, right?
Absolutely.
All right, so you've seen something suspicious. You've got your differentials in mind. You understand the likely why. How do you actually confirm it? Let's talk investigations, then management.
Okay, what tools do we have?
According to these notes, the #1 investigation, almost always, is just a good physical examination.
Just looking and feeling.
Pretty much. Visual inspection, carefully feeling the area palpation, assessing the size, the characteristics. Is it that reducible bulge? Is it red and tender? Does it look like moist tissue? The physical exam is your main tool here.
Are lab tests ever needed?
Sometimes, yeah. The notes mention a complete blood count, a CBC, specifically if you suspect omphalitis. That's to see if the infection is causing changes in the white blood cell count, suggesting a more systemic response.
Right, checking if it's spreading. What about scans?
Imaging, like an ultrasound or maybe other abdominal scans, is actually rarely needed for these typical umbilical things. Usually only if it looks really complex or you're not sure what's going on or you suspect a complication perhaps.
So, bottom line, trust your eyes and hands first. Physical exam is key.
Definitely.
Okay. And then the crucial bit for exams in practice, management. What do the notes say you actually do about these in the UK context?
Right. This is high yield, what's the plan stuff. For the umbilical hernia, the most common approach, interestingly, is just observation.
Wait, you see.
Yeah. The notes state that a lot of them close up spontaneously as the child gets older, maybe up to age 4 or 5 sometimes, as their abdominal wall muscles get stronger. So watchful waiting is standard.
When would you do surgery then?
Typically reserved for hernias that are really large, causing symptoms like pain, don't seem to be closing, or persist beyond that sort of age cutoff.
Okay. Omphalitis, the infection, that needs treatment, surely.
Absolutely. It's bacterial, so it needs antibiotics. The notes also really emphasize keeping the area clean and dry alongside the medication. Good hygiene is part of the treatment.
Makes sense. Granuloma, that little lump.
Umbilical granulomas are usually treated with topical applications. Silver nitrate is commonly mentioned to kind of chemically cauterize the excess tissue, or sometimes direct cauterization. The goal is to remove that overgrowth and let normal skin heal over.
Okay. And finally, the polyp.
Umbilical polyps are typically managed by removing them, usually surgical excision or maybe cauterization, similar to the granuloma, but making sure the whole structure is gone.
So it's really tailored, isn't it? Infection gets antibiotics, lumps and growths often get removed or treated topically, and the hernia often just needs time.
Exactly. Management fits the underlying problem. And what about the long run? Prognosis. Generally, it's pretty good for all of these, assuming proper management.
Yeah, especially that point about hernias often resolving on their own. That's important reassurance.
Right. And omphalitis and granulomas are very treatable with the right approach. Polyps, once they're removed properly and there's no other underlying issue, have an excellent prognosis.
But there's always a but. The notes do warn that delays in treatment or getting the management wrong can lead to complications, and knowing those is vital.
Yeah, this is the what happens if things go wrong part. Really important to be aware of.
So let's cover those complications. What are the serious things we need to watch out for or prevent?
Okay, for the umbilical hernia, the big worries are incarceration. That's where some bowel or tissue gets trapped in the hernia sac, and you can't push it back in.
That sounds bad.
It is, but even worse is strangulation. That's when the trapped tissue's blood supply gets cut off. It becomes painful, maybe discolored. That is a surgical emergency, critical complication.
Got it. Hernia incarceration, strangulation risk. What about omphalitis complications?
If that infection isn't treated effectively, it can spread. Locally, it could worsen into cellulitis spreading skin infection or form an abscess, a pocket of pus.
Okay.
But the really scary one is if the bacteria get into the bloodstream, causing sepsis. That's a life-threatening systemic infection. So catching and treating omphalitis early is crucial to prevent these.
Sepsis is always a huge red flag. Granulomas, can they cause serious problems?
Less likely to be life-threatening, but they can cause persistent low-grade infection. Sometimes they might bleed a bit, or they can just keep coming back if not fully treated. Annoying rather than immediately dangerous, usually.
And polyps, similar risks.
Yeah, similar to granulomas if not properly dealt with, potential for bleeding, secondary infection, or recurrence if some tissue is left behind.
So knowing these potential downsides really underlines why getting the diagnosis right and starting the correct management promptly is so important for all 4 conditions.
Absolutely. It's about preventing these worse outcomes.
Okay, wow. So pulling all that together from the notes, what's the big picture here?
Well, we've basically walked through these 4 key pediatric umbilical disorders: the hernia, the infection, omphalitis, the healing issue, granuloma, and the remnant polyp. We've looked at how different they look, their distinct causes and risks, how you tell them apart, the different management strategies, and crucially, what could go wrong.
And hopefully doing this deep dive, breaking it down piece by piece, helps you see how all those details from the notes fit together. It makes it, hopefully, less overwhelming and much more useful for your revision.
That's the goal, connecting the information so it makes sense and sticks. And maybe a final thought to leave you with, drawing from all this. Think about it. These 4 conditions all occur in exactly the same tiny spot, the umbilicus. Yet, they represent fundamentally different processes. A structural weakness, an invasive infection, a problem with healing, a persistent embryonic remnant.
Huh. Yeah, that's interesting.
It really highlights how important a careful, focused physical exam is, doesn't it? Even in a very small area, you can uncover completely distinct underlying pathologies just by looking and feeling carefully.
That's a great point to end on, and that brings this deep dive into pediatric umbilical disorders based on those MSRA notes to a close. We really hope breaking it down like this has been helpful for your revision.
Remember, this kind of detailed understanding is exactly what assessments like the MSRA are looking for.
And if you want more revision materials like this, structured to help you prepare effectively, do check out the resources available.
Yeah, definitely take a look at pastthemsra.com and also freemsra.com. Lots of good stuff there.
Keep digging into these topics. Keep learning.
Absolutely. Keep up the great work.
We'll catch you on the next deep dive.